A very good afternoon to one and all present here. I thank Dr. Arul sir and AIOS for giving this opportunity. I would like to start and continue by saying that what all Dr. Jayanthan had spoke, and in his end slides you must have seen a set of limitations which he had for keratometry. I would like to say that all what I am going to talk is all the limitations which are there in the keratometry is what we can do with the help of topography. So we know that IOL power calculation in difficult situations, we have a numerous number of data and so many problems with IOL calculation. But I'm going to highlight on the first three only, which are the most important over here, which I'm going to talk about. We also know that there are a lot of corneal scars which can be either in the central or periphery, which causes these problems. Time. Okay. Yeah. And we know that there are a lot of degenerative conditions such as dystrophies, keratoconus, pterygiums, and all other corneal problems which are causing problem with IOL calculation. We have a lot of post-refractive surgeries from the times of RK to the latest advances in lenticular extraction. And we also have all different types of lamellar procedures which we will have to face with IOL power calculation after they develop cataract. The use of topography is also very useful in toric IOL because before we know that only the anterior part of the corneal topography, that is the placido-based discs, were taken. Then we realize that overcorrection of eyes with the rule astigmatism, and there is a lot of undercorrection of eyes with against the rule astigmatism. So we have to utilize both the anterior and posterior corneal astigmatism with the axial length on the same machine to calculate toric IOL power calculation. So coming over to the first talk of post-RK. So we know that there are changes happening both in the anterior and the posterior based on the depth of how much of the RK which is done. You can take an ASOCT for that guidance as well. And there are three main errors which can cause a hyperopic error in myopic patients. That is the keratometric refractive index, the radius error, and the formula error. And one thing during the surgery also, we know that there can be a lot of mechanical instability. There are chances that these RK marks can open up if the pressures are too high, and that may result in stromal edema with a hyperopic shift once the edema decreases as well. Central flattening happens with some amount of peripheral bulging as well. So the flattest central K on the topo is the most important, which we will have to take. And the standard keratometry trends to overestimate the corneal curvature, and we expect a hyperopic shift post RK patients. So the flattest central K is used for IOL power calculation. So the three factors which I said, one is the refractive index error. That is any laser vision correction, it alters the anterior curvature, and the posterior curvature is usually unaltered in laser vision correction. So the standard kerometers and topographers measures both the cornea incorrectly. In myopic classic, it overestimates the corneal power and underestimation of IOL power in post-hyperopic shift. Conversely, in hyperopic classic, you have an overestimation of IOL power causing a myopic shift. So these two things we should always keep it in mind whether the patient has undergone a hyperopic classic or a myopic classic. Based on the optical zone and some amount of decentered ablation also can cause changes, because we know that the topography is going to change it takes the 3 mm, the 5 mm and the 7 mm. If there is any decentration, we know that some amount of ablation is going to happen where the topography is going to be taken. And after myopic classic, the flatter K leads to an underestimated effective lens position as well, and underestimation of IOL power. Likewise, for hyperopic classic, you will have an overestimation of the lens power after because of the change in the effective lens position. Nowadays we have the online Barrett True K formula, which is there available in their website. I use the apacrs.org. It is a very simple website where you have to decide whether the patient has undergone a myopic, a hyperopic, or an RK. And all the changes which will have to write is the K readings. If you have the available data, that is how much they have done for myopic classic, how much their K value of, the discharge summary, it will be very helpful. But this one website is so useful that even though you don't have all the data which is there present pre-LASIK, you can still get an estimated value of the IOL power post. You get an average. So what about high corneal astigmatism cases like keratoconus and some irregular corneas? So these are, when they have a regular astigmatism, they are ideal for toric IOL. You should just make sure that the keratoconus is not worsening, there is no changes, and also they might be patients where you have masquerades of either PMD or Tyrians as well. Optical biometry and Barrett online toric calculator, I come to a conclusion after doing both together. And in irregular astigmatism, that is keratoconus, post-surgical and other irregular corneas, always make sure that you take the topography. The formulas which consider only axial length and not the keratometry to evaluate the effective lens position usually gives a good predictive outcome of the true IOL power. The K reading which has less of this effect in the Hoffer cube formula, and overestimation is not a factor with Haig's formula as it does not use the K reading in estimating the lens power. So what about post-keratoplasties, be it keratoplasties or DALK or any other thing where you have suture-related astigmatism? The IOL implantation either can be of two processes. One, it can be beforehand, that is a planned triple procedure where you do a cataract with an intraocular lens implantation based on the IOL calculation done for the other eye. Or the best way is actually to leave the patient aphakic with an intact posterior capsule. Then after you remove the sutures after 6 months or 8 months based upon the surgeon's comfort, then take a K value based on topography and then plan an IOL. That will always be the best way. Because sometimes what we might face situations where the IOL calculation with the sutures will be so good that the patient will be reading very nice and you will be in a fix whether to remove the sutures or not. Because once you start remove the sutures, the astigmatism is going to change and the patient's vision is going to drop. So optical biometry is actually preferred in these eyes. You can take the biometry from the fellow eye, and central corneal power value inputs are mainly from the tomography. Always use a third and fourth generation formula. Toric IOL can also be preferred to correct high astigmatism. Piggyback lenses, sometimes you place a lens in the bag. It can be an acrylic or silicone. This is the best combination for silicone lenses. And this make sure that that is a single piece lens placed in the bag, and the second lens should be a 3-piece lens in the sulcus. And regarding the choice of IOL post penetrating keratoplasty or any LASIK, so the IOL with negative spherical aberration would be correct for spherical aberration induced by a myopic LASIK. Refractive multifocal IOLs further reduce the contrast sensitivity and increases the spherical aberration and are not recommended. Diffractive multifocals is not preferred as diffractive rings adds to already multifocal cornea, so it is definitely not recommended. Following RK, always avoid using refractive and diffractive multifocal IOLs. So I always use the rule of 2s for the patients who you feel that after implanting the IOL that you are not having the desired outcomes. Wait for 2 months, see 2 different times whether the patient is having any change in their refraction, and then after 2 sequence visit where there is no change, you can either plan for a piggyback lens or a lens exchange. So finally, there is actually a triad of things to be seen. That is the biometry, the topography, which I have the Sirius, and the online calculator. I try to take the value of all 3 entered together. I try to come to a common value, and definitely depends upon the surgeon's expertise where they decide whether they want to put in penetrating keratoplasty, whether they're going to put a scleral incision, whether they're going to be clear corneal. In RK marks, mainly make sure that you don't put an incision where the marks is already there. Put it in between the marks, and those kinds of planning, please do it pre-hand. So that brings the best possible outcome. Thank you.
Thank you, Nishanth. Any questions from the audience on the topography for biometry? If not, I'll just make one observation. Both the previous speaker and Nishanth just made a passing mention about the corneal refractive index being one source of error. Because every keratometer assumes the corneal refractive index to be something. Depending upon which country manufactures that particular keratometer, be it an automated one or a manual one, the corneal refractive index is assumed slightly differently. So when you actually read out the K values in diopters, it is fallacious. The reading is taken in radius of curvature in millimeters. That is converted into diopters using a refractive index. And this is assumed differently in different countries. One. Now it is also assumed differently by each person who's designed the formula. So you're entering it as 45, 47, 48, while that formula is converting it into millimeters and taking it in. Another formula would be taking it in diopters, another one formula will take it in millimeters. It does an internal recalculation. If that recalculation is based on a different refractive index, you're on double whammy. This alone can give you 0.5 to 1 diopter surprise. So what is the take-home message? Your brain is fixed on 45 is normal cornea, 48 is steep, 42 is flat. Keep that in the mind. But what you write down only in millimeters and enter in millimeters. And this is one advantage when my talk comes, while optical biometers are great because they read both, and whatever the formula asks, it feeds it in. So you don't have this headache. Am I right?
True, sir. Changes from 1.336 in few machines to 1.36 in other machines. So that
and the formula also.
Exactly.
So if the formula is going in the opposite direction, you had it. If the formula is going in the same direction, it's fine.
That's where the biometry comes, sir.
Okay.